had a patient that came in with a bottle that said GLP-1 on it in big letters. What it was some sort of supplement that they had just slapped a GLP-1. It was really like magnesium, some B vitamins, but the patient thought that this was some sort of GLP medication they were receiving was helping with their diabetes.
I think one of the jokes that I have with a lot of the people that I see in my clinic is that, isn't it so great then that we get to see each other every 3 to 6 months? We don't have to make a decision that lasts the rest of your life today. I'm going to see you again in 3 to 6 months, and we can always reassess. We're not making any lifelong decisions at this moment.
Welcome to Medication Talk, an official podcast of TRC Healthcare, home of pharmacist letter, prescriber insights, and the most trusted clinical resources. On this episode, listen in as our expert panel tackles real-world questions about GLP-1 agonists, from starting them and setting expectations with patients to strategies for switching agents. You'll also hear them review key considerations to limit muscle loss with GLP-1 agonist use and discuss why some patients hit a plateau or don't respond to GLP-1 agonists. Our guests today are Dr. Jennifer Clements, a clinical professor and director of pharmacy education at the University of South Carolina College of Pharmacy, School of Medicine, Greenville. She specializes in ambulatory care, diabetes management, obesity, and endocrinology. And Dr. Jen Trujillo, a professor and the Associate Dean for Education at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. She practices as a clinical pharmacist and certified diabetes care and education specialist at the University of Colorado Health Diabetes and Endocrinology Clinic, where she specializes in diabetes pharmacotherapy and advanced diabetes management. You'll also hear practical advice from panelists on TRC's Editorial Advisory Board. Dr. Stephen Carrick from the USC School of Medicine, Greenville, and Dr. Craig Williams from the Oregon Health and Science University. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. For the purposes of disclosure, Dr. Clements reports a relevant financial relationship by serving on Speakers Bureau for Novo Nordisk and Eli Lilly. The other speakers you'll hear have nothing to disclose. All relevant financial relationships have been mitigated. Now, let's join TRC editor and clinical pharmacist Dr. Sarah Clockers and start our discussion.
So to start us off, Jen, can you give us a brief overview of how you help patients address some of these challenges when starting a GLP-1 receptor agonist?
Well, I think for me, I try to think about 3 big ticket items when I'm starting someone off. The first is setting clear expectations. The second is starting low and going slow. And the third is really normalizing the experience. So when I'm thinking about setting expectations, I want to be clear with them about what I expect they will see in terms of benefits and side effects. I try to explain why we titrate the dose over time. And I try to talk through kind of what's normal to expect versus what's not normal. So, if you feel a little full or mildly nauseated, that's really telling you that the medication's working. But if you're vomiting repeatedly and can't keep fluids down, that's not okay. And I need to know about that. And then in terms of starting low and going slow, just really explaining the why behind that, emphasizing the basics of administration. So eating smaller meals, eating more slowly, stopping eating when you feel full, making sure you're staying well hydrated, and telling patients, you likely won't eat the same way when you're on a GLP-1 as you did before. And then I think having a touch point 1 to 2 weeks after they start is just a good way to make sure that they are off and running. And then that last point about normalizing the experience, I try to normalize that titration phase. Like, week 1 or 2, that's really just an adjustment. And you're probably going to see things like appetite changes before you actually see the weight changes. And everyone needs a different dose. So your neighbor might be on one dose and you might be on a different dose. And we just want to find out what's going to work best for you.
And I think another barrier that folks run into is how do we get these covered? But Stephen, I was hoping you could chime in on any tips you have for helping your patients with the cost and coverage of these medications.
Oh gosh, I wish there was a simple answer. I always lean on my outpatient pharmacist and at our clinic to help with that. There's some tools that are in place. I think one is sometimes trying to connect patients with manufacturer cost and whatever programs may be available. But I know that for some, there may be certain income barriers or paperwork that may limit that. Second is we were fortunate that we have a pharmacy adjacent to our clinic that's able to offer some of these medications at 340B pricing, so some reduced costs. And then I think thirdly too, within our EMR, as long as the patient's insurance is up to date, that will occasionally be able to provide some information on insurance coverage. I mean to say all that too, in the sense of a lot of these medications for the sense of bariatric purposes, I think that's providing the most barriers to getting these medicines affordable for patients. But because of the expanding indications, not just diabetes, but for patients with high cardiovascular disease risk, for maybe they have hepatosteatosis, maybe they have sleep apnea, the number of diagnoses that we can now attach with a prescription for a GLP-1 is expanding. And I think that is probably the biggest thing that's led to ease of affordability, because now we're seeing more insurances covering these medications for reasons outside of just bariatric person and diabetes.
Also, briefly say that, as far as costs and coverage, we reminding our medical residents on the hospital side and the clinic side to make sure you ask patients about if they're getting them somewhere else. We occasionally have patients who are getting them outside of the traditional healthcare system and acquiring them on their own. Ask about them along with other over-the-counter things and things that may not be in our system. So,
Yeah, that's a really good point, Craig. I forgot to bring that up in the sense of just all these other third parties that are distributing these. And even I had a patient that came in with a bottle that said GLP-1 on it in big letters. What it was some sort of supplement that they had just slapped a GLP-1. It was really like magnesium, some B vitamins, but the patient thought that this was some sort of GLP medication they were receiving was helping with their diabetes. So there definitely is a lot of things being out there that are just have a GLP-1 label on it that are definitely not the medication, but may influencing some decisions patients are making in terms of supplements and just other things that they're trying to take.
Great points. Thank you. And I think the boxed warning around thyroid cancer has scared some folks. And so, Jen, I was hoping you could comment on the risk of thyroid cancer and how you talk to your patients about it.
The boxed warning for the GLP-1 RAs comes from rodent studies, really where dose-dependent C-cell tumors were observed. I think that context is really important here because rodent thyroid C cells are different than human C cells, and humans, we just haven't seen that clear causal signal for medullary thyroid carcinoma. So I think that the black box warning is really out of an abundance of caution. So you've got contraindication with a personal or family history of medullary thyroid carcinoma or patients that have multiple endocrine neoplasia type 2. Medullary thyroid carcinoma is the most rare form of thyroid cancer. And again, this hasn't been seen in humans, it was only seen in rodents. So I just try to put that into context for folks. People get worried when they have hypothyroidism and they're taking levothyroxine. That makes them worry. Can I still take a GLP-1 RA? Yes, absolutely. So really, I think putting it into context is what I try to do.
Excellent. We've had some reports of patients presenting to the ED with extreme anxiety or mood changes after starting a GLP-1. Jennifer, have you seen this in your practice, or do you have any comments on that?
I haven't seen anybody go to the ER maybe with a possible panic attack and be associated with their GLP-1 therapy. I will say that, of course, this is a warning and precaution about changes in their mood, the risk of maybe suicidal ideation or behavior. The evidence is mixed, but it's evolving. There's even been recent news reports that perhaps the FDA will remove this from the package insert and the labels for the medications. I think, regardless of the population we're talking about, right? If we are treating diabetes, there's diabetes distress. If we're treating obesity, we know that we have to address stigma and bias. They may be internalizing emotions and feelings as well. So it's, I think, still important to do baseline screening. That's very important and it's key in clinical practice. But when someone comes back for their appointments and they have a history of depression, you can, still follow up with questionnaires and ask about their mood, see if there's any changes. But I've actually seen probably an opposite effect that when people do lose weight, they become more active. They feel as though they can do more. And in fact, their mood improves and they start to gain those long term benefits with the medication. And that actually enhances their quality of life and improves their mental health.
I think my experience has been very similar to Jennifer's in what I've heard from the patients that I have in my own clinical practice. I haven't seen any extreme anxiety or significant mood changes, except in the positive direction. I do think it's interesting, though, hearing some things on the national news or in reports of subsequent consequences of significant weight loss, things that you used to do with your partner, going down to your neighbors and having a few beers and some pizza doesn't become as enjoyable for you as it used to be with your partner. So I think it might create some new challenges that may come to the surface as a kind of side product of losing weight, changing your lifestyle. But I haven't seen any direct reports of these medications causing extreme anxiety or mood changes.
You also add, sir, that as far as being concerned that the drug itself has like neurologic causes or toxicities, also have not appreciated that. But I think Jen's maybe hitting on something that definitely has made the lay press. And we have had a couple bedside conversations with patients along those lines of just, your body, for a lot of these patients, they've been overweight and obese their entire lives. And it's a pretty big deal to lose 80 or 100 pounds. And it may have impacts on your social life outside of that. So I think mostly positive for the patient, but does affect relationships with, friends and spouse and children. And because I think for some of them, this is kind of part of their identity, kind of what they've weighed and for what they've weighed for much of their life. So while they appreciate the health benefits, I think we are seeing some of the social implications or complications of, kind of not being that person they were for most of their life.
One question that we get very frequently is how long can patients use GLP-1 agonists? Jen, would you want to comment on that, on the data we have?
I think that GLP-1 RAs can be used chronically. They have been available for 20 years now. They are considered chronic therapy for type 2 diabetes. And like other cardiometabolic conditions or medications, they are intended for long-term use as long as they're effective and well tolerated. I think their utilization for weight loss is much newer. We don't have all the answers about the most optimal duration of therapy. I think many consider them the same way as chronic therapy for a chronic disease. And if the medication is stopped, we know that weight regain is common. So for many patients, this is not a short-term intervention. With that said, many studies really indicate that about 50% of people stop taking a GLP-1 RA within the first year of treatment. So while I consider them to be chronic medications, we're not seeing that pan out in real life. We're seeing people not want to stick with them for the long haul. So I think it's a really important question. But I think from what we know, we can use them long term, specifically, definitely for type 2 diabetes. And I think we can for obesity and overweight as well.
To Jen's point, so it depends on what you're on it for. And, for some of the non-diabetes indications, it needs to be long-term if you want to get the benefits. But for weight loss, where we're seeing a lot of people use it, then then yeah, if we can get to a certain weight goal, let's try at least a lower dose or try coming off it. So we've probably all had some experience with patients who can successfully come off them and at least not regain all the weight, maybe maintain at some level they want to.
I'll just add to that. I think one of the jokes that I have with a lot of the people that I see in my clinic is that isn't it so great then that we get to see each other every 3 to 6 months? We don't have to make a decision that lasts the rest of your life today. I'm going to see you again in 3 to 6 months, and we can always reassess. We're not making any lifelong decisions at this moment. And I just think that shared decision making and that collaboration over time really makes a big difference.
Yeah, and as you add briefly that when patients do lose a lot of weight, they feel so much better that we have had a couple patients who the motivation kind of changes to keep the weight off when they get it off, maybe as opposed to trying to lose it kind of in the first place. So we have had some patients be able to come off it and maintain pretty close to the weight they want because they're just feel so much better at that weight.
One question that's come up regarding side effects and also efficacy is, are there times where you ever adjust the dose or the interval between the doses to help with that, even though they're not studied like that?
I don't proactively suggest extending the interval, but I do definitely support and collaborate with my patients that take that approach themselves. So I just want to be part of the decision making process, and I want them to feel like they can collaborate with me and be honest with me. So I have a few patients on tirzepatide that have extended the interval and have found kind of a sweet spot for them, something that works for them. And they'll tell me, like, 10 days is the right spot for me where I still see that my glucose is well controlled, but I get some side effects, more intensely the first day or two after I take it. And that 10-day mark just seems to be a very reasonable middle ground that works for me. I have a couple patients who, for semaglutide, they do kind of half a dose twice a week instead of the full dose once a week. And again, I don't ever proactively suggest that, but I try to work with my patients that have found strategies that work for them.
Yeah, I would only add to that, Sarah, that I mean, if the indication is diabetes control or weight loss, yeah, I mean, maybe a bit more open to if patients say this works for me at this dose and I feel better, and either they're maintaining glycemic control or they have the weight loss they want. I've done enough digging through FDA approvals and reviews to know that, the doses and durations that companies release drugs at doesn't mean that's the only dose that works for everybody. So we definitely stick on label when prescribing, but yeah, if the patient finds something that works for them and it's meeting the goals of their disease, I think that's a perfectly reasonable approach to take with that patient.
Excellent. That's a great segue to digging into some GLP agonist questions for patients with type 2 diabetes specifically. We're seeing them more often as we continue to individualize initial med choices, considering those relevant comorbidities. And so, Jennifer, can a patient on insulin also use a GLP-1 agonist?
I can make this very simple and yes, they can. That is supported by the guidelines. You can look at the most recent 2026 American Diabetes Association Standards of Care. They have a nice algorithm in section 9 where they talk about all the medications for type 1 and type 2, but this particular algorithm towards the back of that section really reference how to use them for type 2 diabetes. And so GLP-1s are preferred injectable. There are times where insulin is initiated based on their A1C, being symptomatic, unexplained weight loss. But yes, they can be used together. We know that once the GLP-1 is added or the insulin is added, which way the combination is kind of starting and going, the risk of hypoglycemia goes up. But by adding the GLP-1 RA on top of that, you're able to lower the dose of the insulin. And often, that's about a 20% decrease. That's what I've done. Decrease initially to prevent hypoglycemia. It's a time to review prevention and treatment of hypoglycemia, to educate on monitoring, perhaps give them a CGM if they already don't have one. But there is evidence that, yes, we use them together. I will say, though, we're using them because we know the benefits with GLP-1 receptor agonists. In addition to weight loss, in addition to A1C, but there's still other benefits we're wanting the individual to gain, such as the cardiorenal benefits.
Excellent. So we know patients are often on multiple diabetes meds to get their goal A1C, and we've already talked about, using a GLP-1 agonist with insulin. So Jen, what factors guide your decision to either maintain, reduce, or stop a certain drug once a patient reaches their A1C goal?
I feel like I go back to what I teach my students, which is who are evaluating four things: efficacy, tolerability, ease of use / treatment burden, and cost. And I think about how the better control you have early on in the disease of diabetes, the longer you're able to maintain that great glucose control. So for medications that have a low risk of hypoglycemia and are reasonably well tolerated, I'm going to celebrate that great control and not want to discontinue it. If I'm using medications that have a higher treatment burden, heavier cost, or have side effects that I'm really trying to avoid, like weight gain or hypoglycemia, those are really going to be the first ones to go. And a lot of times, I think these days, we're trying to make room for the agents that also have added benefits beyond glucose control. So the GLP-1 arrays, the SGLT2 inhibitors, sometimes we're making room for those. And what a beautiful thing, a potential excuse to get somebody off of a sulfonylurea, which causes hypoglycemia and weight gain and just isn't all that effective and puts a lot of burden on the pancreas to make insulin. So sulfonylureas are going to be the first ones that I want to try to discontinue, followed by rapid acting insulin if they happen to be on that. And then, trying to reduce the basal insulin over time and hopefully being able to get somebody off of insulin is a real win for me. And then keeping patients on the medications that have benefit beyond glucose control. Those are really the approaches that I'm trying to take when I'm adjusting those diabetes notes.
One thing I'll add is I wonder if you're, unlike using, ACEs and ARBs for hypertension or the other diabetes medicines for the most part that preceded this, most of those medications, you're on them chronically to manage your chronic disease. They don't fix. I mean, metformin doesn't, fix the diabetes. The interesting thing here, since obesity and the lack of activity that often comes with that is the cause of diabetes, we are dealing more with what happens when a patient loses 80 or 100 pounds and their A1C is truly normalized and they're still on these medications that don't cause hypoglycemia. So maybe you don't have to stop them to avoid adverse effects, but do you really still need these medications when you've lost that weight and your A1Cs 6 or 5.8. And we have had some of those conversations. And then what becomes appropriate in that setting? As I say, I'm always someone who loves when a prescriber or patient says, I'm on more medications than I want to be on. What can I come off of? So,
It's an interesting debate between the definition of disease remission versus the definition of disease controlled. If somebody's on 3 meds and has a great A1C, that doesn't mean that they don't need those meds anymore. Certainly, a trial of less meds, is appropriate in some cases. What I see, though, that I worry about in clinical practice is some folks that are seeing a person get to an A1C of 6.9 and wanting to stop metformin. And, there is still evidence that a lower A1C still has an impact on microvascular complications. So an A1C of 6.9 doesn't tell me or doesn't signal to me that I should stop the medication that is helping to or is contributing to that A1C. But to Craig's point, when you get down in the fives, it's, of course, going to be a topic of conversation.
Thank you. Jen, have you seen tolerance or a plateau effect to a GLP-1 agonist after a few years of use? And if so, how should we manage this? What do you do in your practice?
I mean, in clinical practice, yes, I feel like we talk about plateau effects, I think people, some of my patients will say, my ex GLP-1 agonist was working great for a while, and now I feel like it's not working anymore. I don't really think it's a true pharmacologic tolerance, but maybe perhaps it's more of a physiologic adaptation. I don't know. Like you see, I mean, we do know for weight loss, most weight loss with these meds occurs in the first 12 or 18 months. And then the body maybe reaches a new metabolic, steady state, and that's expected. I guess I wouldn't call that a true tolerance, but maybe there's just some plateaus because energy expenditure adapts, or maybe appetite signaling recalibrates. Maybe there are more missed doses. Maybe caloric intake has crept up. Maybe they're not on the most appropriate maxed out dose that they should be on. So I don't feel like I have a great answer because I do feel like we talk about it in clinical practice, but I'm not completely convinced that it's due to something like GLP-1 receptor downregulation or something like that.
So after addressing all of those, different situations, addressing diet, addressing maximum doses, do you switch folks to a different GLP-1 agonist to see if they get any further benefit?
I sure have. I mean, I think that there are some differences just in efficacy and tolerability between the products as well. So, if we're able to use a different GLP-1 that can still get covered and still get prior authorization, yeah, absolutely, I'll switch.
Thank you. And why do some patients not lose weight with GLP-1 agonists?
Yeah, that's a great question. And I know for those individuals, it's probably frustrating because they may have friends that have taken these medications. They've seen advertisements. They hear about them, obviously, and they take them and they don't have a response. I think it varies. What I've seen is non-responders could be anywhere from 10 to 30%, but there's probably a lot of different reasons that go into that. Genetic variability, maybe there's suboptimal adherence or even titration, as we previously talked about. Maybe they're on other meds that haven't been evaluated that's counteracting their progress with their weight, and maybe some comorbid conditions that have been undiagnosed. Again, I think there's many different factors that go into it. Perhaps the best way to optimize support and give them guidance is maybe a referral to a dietitian, work on behavioral therapy, reassess the dose as we previously discussed. And again, with that last question, switching, maybe it's time to consider a switch. I think bottom line, there's many factors into why they may not lose weight.
Thank you. And along those lines, what's the evidence on, muscle loss for patients using a GLP-1 RA and strategies to limit that loss?
I think this question is a little more complicated than it seems. So first, I think when we say, sarcopenia, that's a loss of muscle mass, but also a loss of muscle strength and function. And, I'm not an expert in this, but the studies that look at this measure lean mass, which includes not only muscle, but bones and organs and water. And so that doesn't capture sarcopenia in its entirety because it's not able to really look at strength and function. And then I think on top of that, we see a lot of heterogeneity in the reported reductions in lean body mass from GLP-1 RAs in clinical trials. So I think it's a little complicated, but systematic reviews of GLP-1 RAs in humans show that lean mass contributes to maybe 20 to 50% of total weight loss. And when you think about losing weight solely just through calorie deficit without exercise, they quote about 20 to 30% of total weight lost is through lean body mass. So 20 to 50% with GLP-1 RAs, 20 to 30% if you're talking about calorie deficit diet without exercise. So to me, that seems like fairly similar. So if you are going to lose weight at all in any way, some of that's going to be muscle. I don't think that all of the evidence is out yet. So more to come on that. I think people are looking at this pretty closely. But with what we know right now, what I talk to my patients about is just that it becomes incredibly important to exercise and do some strength-based exercising, that it's really important to eat nutrient-dense foods. So if your calorie intake is going to go down, you got to make sure that the calories that you're taking in are really nutritious and that you're getting enough protein in your diet. Those are the two things that I try to focus on, and just trying to kind of bring home that message to patients that any type of weight loss, you're losing all the parts, muscle and fat.
Stephen, do you have anything else to add?
No, I sort of counsel the patients in a similar fashion. I said that tell patients these medications, you're going to lose weight anywhere and everywhere that you can. I 100% agree. And this is sort of a gap too. And I think in many physicians counseling is that we tend to emphasize exercise in the sense of cardiovascular exercise, walking, jogging, swimming. But oftentimes we forget to emphasize the strength training and resistance training component of this, and try to make sure people are getting 2 days a week of resistance activities, whether it's body weight, resistance band, up to weightlifting. I think is so critically important, not just for maintaining lean muscle mass and muscle function, but also we talk about bone strength, which could also be potentially complicated with GLP-1 and some of this weight loss. I mean, coordination, worrying about when people lose this muscle weight, their increased risk for falls, fractures. I mean, I think the second part, as Jen said, is with nutrition, trying to target lean, healthy, nutrient-dense foods, proteins particularly, as I think 1.2 to 1.6 grams per kg ideal body weight is a goal to try to get through. But try to make sure people intentionally incorporate protein, whether it's animal-based proteins, plant-based proteins, legumes, nuts, lean meats, fish. I just want to make sure people are taking more of those, and ideally, hopefully, less of the processed foods. Sometimes that's a challenge, especially when these medicines suppress appetite so much. But when I do, I want to make sure they're eating what's good and can help their body be replenished and restored. So much of this conversation too is now optimization of health. It's a complete change in paradigm from treatment and reduction of disease to now we're trying to really optimize health and think long-term for the patient. But especially too, if we're trying to think about getting these patients off these medications, just reinforcing those healthy lifestyles.
Thank you, Stephen. So I do want to just quickly address switching because we've had a lot of questions about that. How do you switch? Do you need to start the new one at the starting dose? Can you convert? Craig, Jennifer, have you run into this, and can you kind of guide us through the process?
Our general approach is you can, make a table of kind of typical dosing and kind of compare, but I don't have a good 1-to-1 milligram per milligram conversion between them. So you don't have like an opioid conversion table equivalent for GLP-1s. I will say though, if someone's been doing well on what is kind of a medium or high dose of injectable GLP-1 and they need to switch for insurance reasons, we do not go back and start at the beginning and retitrate up. We become pretty comfortable starting at what seems like kind of a comparable dose for that agent, and that generally seems to have gone pretty well. So, but I've had not much experience moving back and forth between the orals and the injectables, but that's been our approach for different injectables.
I haven't switched from orals to injectables. It's always been more of a conversation of how comfortable we feel with injectable to injectable and where they are currently with the dose on their injectable now versus where do we feel comfortable going on a new agent. But I do think it's a good conversation because pretty soon we're probably going to have another oral product on the market based on what I know about it. And so some of its evidence has been looked at following a course of injectable therapy so that it can help maintain weight loss, knowing that maybe some people don't want to inject long term and that switching them then to an oral agent would be the best option. I do think that is coming, but always the conversation has been more of switching injectables to another one. Do we have to go back to the beginning or do we feel comfortable, like if they're on semaglutide 2.4 milligrams, that I can start tirzepatide 5 and skip the starter dose.
And then if you have a patient off of a GLP-1 for quite some time, do you always restart them? Or if they were tolerating, say, a higher dose and then they missed it for a couple of months, would you just jump back into that higher dose? What have you done in practice, Jennifer?
Yeah, I mean, there's times, I'm not gonna lie, that we start right back from the beginning because perhaps they were an individual that tended to have a little bit more nausea, vomiting for every time the dose was previously escalated. However, I always say, how long have they been off of it? I think that comes up when people have planned procedures. Sometimes they get told that they have to go back to the beginning because they held it for a week, or, in case that got extended a little bit, into week 2 or something. But if they were fine before, you could, in my opinion, restart. They were on a really high dose and have been off of it, you know, I think that's obviously a conversation with the patient. Do they feel comfortable? Do they understand what may happen? I wouldn't recommend starting, tirzepatide 15 if that's where they left off 6 months ago. Maybe I would feel comfortable with 5. If they are like, "Just start me at the beginning," that's great. But I do know that, sometimes insurance companies may limit you, particularly when we're looking at obesity, with some of those doses that you're using to get to the next maintenance dose. And so what I mean is that insurances may limit you to just 1 month. So that's a conversation that you also need to have with the patient, and check to see if there are going to be those limitations tied to it.
Yes, that's a good point, that it may not be our choice in terms of whoever's paying for it definitely might have some say in that. I think context matters. If the question is, if you're switching between agents because insurance changed or something got dropped, then yeah, we're comfortable kind of going to what seems like a comparable dose. But to our earlier discussion, if you're changing because someone wasn't tolerating the one you're using, then we will generally start at the lower dose, because higher doses definitely have more adverse effects for most patients. And so we want to set that patient up to succeed. If we're changing because they were intolerant of it, we'll always start at the beginning. And I think if they've been off it for a long time, I mean, generally lower doses are better tolerated. So we are generally starting at the starting dose if they've been off it for a long time, and we're reinitiating in that patient, no matter what their experience was with it previously.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or prescriber insights subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code MT1026 at checkout. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.